And without any further delay, I'd like to introduce our next speaker, Dr. Scott Lee, who we know for the majority of his good sense of humor. And Scott trained, got his MD degree at Jefferson Medical College and trained in internal medicine at the University of Colorado and GI fellowship at the University of Washington with a stint in the University of Chicago as well. Right? Thank you. And Scott needs really no introduction as a leader in the Northwest with his efforts really to push the Northwest to be on the map for advanced IBD care. He's a wonderful clinician and a key investigator in many of the landmark trials in the nation and internationally. His publication record is incredibly rich. I always say this, that nobody has done more for the education in IBD in the Northwest and beyond more than Scott Lee, and it gives me a great honor to introduce him as our next speaker. Thank you.
Thank you, Dr. Wabe. Thank you, Dr. Abraham. I didn't know we were going to go there, so any disparaging things I say at this moment are made up in the last 15 minutes. So the usual disclaimers, and how about some real disclaimers about this talk? So I think Brian said yesterday, you don't have a lot of references in there. I said, yeah, the data just confuses things. I like the personal communications, which are usually the voices running in my head saying that's the right thing to do. So unlike Dr. Abraham, I'm not going to show you a lot of fancy slides, but I will show you what I believe is the correct thing. So de-escalation to me in this context is you're going to dose reduce or you're going to discontinue a medication, right? So we only want to look at the patients, despite the fact that she thinks I don't know how to de-escalate. There's those that are in remission, right? It makes no sense to take someone who has active disease and say, well, let's stop your medication. Exclude those who interrupt for other reasons. Infection, you notice that was her case, infection, right? So that's, I'm excluding, right? So these are side effects, insurance lapse, loss of response, adverse reactions. So, right, those aren't elective de-escalations. Those are, we're being forced to by a medical reason. Okay. So I'm also going to go more into class of medication because there's differences, right? The biologics have different implications for discontinuation or dose reduction than what we would call conventional therapy. And I would say to you, really the reasons to de-escalate are safety, cost, maybe preference. And I'm not sure the last one, that's more of a subjective thing. So with that, right, we can't forget, I know the world has moved on to biosimilars and biologics and all of these new medications, but let's not forget that mesalamine still exists and we still have a lot of patients on it. So as you notice, Dr. Abraham ignored this portion, so I'm just saying, as complete as your talk seemed, there's some gaps. So long-term therapy is safe with relatively low cost. And there's actually a reference in this slide. So, right, so we know that a dose of greater than 2 grams a day makes it more likely that patients will remain in remission. And if you were to discontinue, meaning you go to placebo, right, so you start someone on mesalamine and then you take half of that group and put them on placebo, a significant higher number of patients on placebo will flare. That's a discontinuation. And the number needed to treat with mesalamine is only 4 if you keep them on therapy. So it's relatively low number needed to treat, higher likelihood of a flare. There are no concerns with reinitiation, and this will come up with the biologics where there are concerns with reinitiation. And we know that higher disease activity equals higher risk of complications. So patient choice, maybe they don't want to take pills. Cost shouldn't be a huge issue with the mesalamines. So with that said, how about the patient that says, you know, I've done really well, 10 years, you tell me I've got complete mucosal healing, I want to stop. Well, one of the things that we can't forget is the colon cancer risk, right? And I think we've moved on a little bit from this, but I think it's still germane that we believe if you heal the mucosa, you put the patient in remission, colon cancer risk goes down. But again, this is a study from 2005 by Fernando Vallejos, and you know, he basically said, okay, well, what is the risk of dysplasia in cancer? And it turns out if you remain on 5-ASA at about 2 grams a day, you can show that there's a lower risk of dysplasia. So there's a reason not to de-escalate mesalamine, right? Beyond the typical flares, that we might be preventing colon cancer. Okay. So my conclusions on mesalamine, which she glossed over, would be I don't think there's a good safety reason to de-escalate. I don't know that there's any good evidence that says 1 year of mesalamine, 10 years of mesalamine is more dangerous. These are relatively inexpensive. I guess that's again, relative term for patients. De-escalation equals higher risk of flare. So these are all con. And if you flare, you're active disease, higher risk of dysplasia. Pill burden, cost. I mean, colon cancer, flare, I don't want to take pills. That doesn't make sense to me. Take your medications, okay? So I don't think there's a generalizable reason to de-escalate. If you or your patient want to de-escalate, I think they will tolerate a restart, which will become an issue with some of the other medications. They may respond, but I think we've all had those patients stop their medication, terrible flare, we put them back on the same medication, and they don't go into remission. And if you do that, again, I think what's most important, beyond the fact that I think that that's not a good idea, is continue to monitor them, right? Don't just let them go and say, okay, we'll see you in 3 years. So you got to keep monitoring, whether that's fecal calprotectin, colonoscopy, X-ray, CRP. Continue to monitor them. Okay. So what about other conventional therapy? Azathioprine, which, azathioprine or 6-MP. We know, and I think Dr. Abraham would admit this, that the longer you're on azathioprine, you start to see a risk after 2 years of lymphoma, skin cancer, cervical cancer. Okay. And this, I think, will be an important point because she brings up the STORY trial and then she says, well, half the patients are still doing well. I would say, I agree with her, half the patients are doing poorly. Okay. But then she says, all of them go back into remission, but most of them have to stay on azathioprine, right? And so this is going to be a critical point here, right? So if we want to de-escalate, well, what about azathioprine? So, okay, efficacy. We know discontinuation after you've been in remission for a long time, there's higher risk of flare, 21% versus 8%. Decreasing the dose, I've seen that. Some patients come and they say, well, I dropped my dose in half. And I'm kind of like, I don't know what that does. We don't really have good evidence that that does anything. There's a couple of studies in Asia where they dose reduced by 50% and the patient stayed, quote, in remission. I guess my main point is you don't know that you've reduced this risk of lymphoma, skin cancer, or cervical cancer just by cutting your dose of azathioprine in half. We don't have that evidence. So, and the cost is relatively inexpensive. So I just want to make sure, because this will come up again, that azathioprine, I think, is the drug that we are probably looking at saying, boy, maybe we don't want to be on this forever. Okay. But I'm not saying she's right about de-escalating azathioprine. I think this should be a relatively moot point in 2017, right? So we have safer long-term regimens. So why would we use something that has higher risk? We have more effective regimens. So why would we use regimens that have lower efficacy? So cost of alternatives, right? So combination biologic is, quote, higher, but who is it higher for? I think it's higher for society, but probably not for the individual patients. A lot of the copay assistance programs, my patients will say my prescription of azathioprine costs actually more than my prescription of adalimumab. So again, cost is a relative thing. I don't think that's a good reason to consider discontinuation. But we need to educate our patients on the concerns of biologics, right? So we know biologics are safer and more effective than azathioprine. We know that their cost may be actually less to the patient, and biologics, well, they're more difficult to administer theoretically. That's not a reason to avoid them. So I will give that thiopurines I would like to de-escalate. But again, I would say this should be a moot point in 2017. So to conclude on thiopurines, de-escalation of thiopurines, safety, yes, there is a concern. So I think I would agree with Dr. Abraham if she were to say we should take patients off of azathioprine. I would say I agree. Efficacy, there's, again, higher rates of relapse, just like we've seen with any medication, biologics, mesalamine. Cost is not a good reason to discontinue. But again, should we really be using a lot of monotherapy with azathioprine? We have very little in our practice. If you agree that this is not a primary therapy, then there's no controversy on to get whether what we're doing with this. And same thing with mesalamine. If you want to de-escalate, patient will tolerate, restart. There's no antibody issues or intolerance. They may respond. Again, anecdotally, I can tell you I've had patients who've been in remission 10 years, azathioprine stop, a year later, horrible flare, can't get them back into remission. So again, I would worry about that. And then continue to monitor. And again, do we really want to use azathioprine as monotherapy? So what about methotrexate? Again, my colleague, I didn't see a reference to methotrexate, and we have the world's leading expert on methotrexate here, Dr. Fagan. So safety, right? Again, I think this was the paper out of Chicago years ago, because we used to worry about methotrexate, long-term toxicity, primarily hepatic, and it was shown there's no association with cancers, no association with liver disease. So really, pregnancy is the main issue with de-escalation for methotrexate. As far as I know, there's not a study that looked at discontinuing methotrexate for people that responded. What we do know, right, from Brian's pivotal trial, that if you start people on 25 sub-Q, you get 40% of people in steroid-free remission. And if you dose reduce to 15 milligrams, you lose about half the patients at the end of the year, right? So there's also no evidence that dose-reducing methotrexate reduces toxicity. So again, I would say, I think we have the evidence that says, yeah, if your patient responds and does well with methotrexate, you don't want to dose reduce, you don't want to discontinue. It's not a safety issue, and you will lose some patients if you start dose reduction. It's very inexpensive, and the main concern is really, right, it's pregnancy, and do we have to use this as a parenteral form, meaning there's pill and a parenteral. I don't think we know that. A lot of the oral studies are all over the map, and you can't tell whether it really works as an oral medication. So again, conclusions for methotrexate, I don't think there's any evidence that generalizable says patient on methotrexate should be de-escalated. Dose reduction results in loss of remission. We know that. So presumably, if you just discontinue it, that'll be worse than dose reduction, right? So little or no duration-related toxicity. Cost, it's very cheap. Primary reason to de-escalate is your patient wants to become pregnant. My personal take is for men, I will leave them on methotrexate, but when women want to become pregnant, we have to eliminate this therapy, okay? So if you or your patient want to de-escalate, you'll tolerate restart, same as the other molecules we talked about, mesalamine, azathioprine. They may respond, and then you should continue to monitor. Which gets us to really, I think, what most people think about de-escalation is the biologics. What are we doing with them, right? So again, while her anecdote of a high trough level, it was very nice and scary for most of you, I'm sure. I don't know of any good study that shows a clear, linear dose or duration-related toxicity to the biologics, whether it's TNF, anti-adhesion, IL-12/23. As far as we can tell, there's no dose and duration. I think there is some odd things like the psoriaform rash that you see with anti-TNF therapy. That seems to be duration related to the duration, meaning the longer you're on it, the more likely you might get a psoriaform rash. But again, no broad safety concerns, no cancers, no infections. Infections will always be there in the background with all of these therapies, with the exception of mesalamine, and my point is immunize them, and we'll talk about what's actually the more dangerous thing, which is steroids. So cost consideration, again, cost to who? Cost to who, right? To patients? It should not cost them a lot for most situations, okay? And so patient and practitioner preference, I suppose they're injections and infusions only, so some patients don't like that. I don't think, again, that's a good reason not to do that. Pregnancy is absolutely in this category, not a reason to de-escalate. In fact, I would say that's a pretty big mistake during pregnancy if you want to stop medication. So what about efficacy? So we talked about safety. Well, we know, right? So these are going to be all the pivotal trials. For infliximab, Act 1, and you put people on... so everyone gets open label therapy, right? And if you respond, then you move on to get randomized. So this would be essentially saying, we put you on a therapy, you respond, go into remission, and then we're going to stop, right? And what happens? Well, okay, so we lose. Dr. Abraham would say, well, okay, you only lost 24%. But look at the numbers, right? We got 40%, which is 40 of 2/3 of people that made it here. So really, do we really want 10% of a very small number? Okay, so again, and all of the biologic trials will show, so this is going to be Accent, which is, the Crohn's pivotal trial, which showed, again, if you get rid of drugs, so you go to placebo, significantly higher numbers of patients are going to flare. Okay, so CHARM is adalimumab in Crohn's, same story, right? Same story again. you're going to have higher rates of flare. Only 18% of you that initially responded still in remission at 1 year. Okay, vedolizumab, been out for about 2 years. What happens? Again, the longer you go out and you go to placebo, which is to me de-escalation, 16% of people in remission. And I don't think I had a ustekinumab, but it looks very similar. Start drug, biologic, stop, which is to me, again, de-escalation, higher risk of flare. So what do we see? We see efficacy, 28 versus 13, 36 versus 12, 42 versus 16, right? But again, if we could really get everyone back into remission, who cares? Well, there's loss of response. So we know interruption, episodic dosing can lead to up to 60%, right, antibody formation rate. This can lead to permanent loss of response with antibody development. And again, presumably this whole biosimilar thing, right, if you lose the innovator, it's not like we think you can just go, oh, well, I'll go to biosimilar A or B because they have antibodies. You're probably still not going to be able to use the biosimilar. So we have a limited number of biologics in our armamentarium. We don't want to lose them. And it's not, again, flare, sure, I don't like that, but it's really the permanent loss. And that's the part that really, I think, moves me to say, I'm not sure I want to stop a biologic. Safety, again, I don't know of any evidence that says long-term this is a problem. So what about combination therapy, right? So you have to consider each medication. In general, there's no increased risk with combination therapy at 1 year, right? So you keep patient on combo, there's no increased risk. Risk of thiopurines, we already talked about 2 years, so we usually try and get rid of that. But that's not de-escalation to me because we normally will then insert methotrexate for the thiopurine that we're getting rid of. So to me, it's just a switch, not a de-escalation. And so Sonic showed us, right, that we know combination is the best, right? So we're a combination monotherapy with infliximab, azathioprine monotherapy. Combination clearly wins as efficacy, okay? Safety, right? So 3.9%, 4.9, 5.6 in terms of serious infections. And honestly, these infections here and here are really related to the Crohn's, the underlying disease. So these are pelvic abscesses, hospitalization for intra-abdominal abscesses. So I would almost say that this is a safer regimen for 1 year, okay? But when you get, so what about methotrexate, combination with methotrexate? Well, again, Brian did the study that said, okay, if you go on to methotrexate plus infliximab versus just infliximab, and actually did not show a significant difference for those who went into remission at week 14 and week 50. But I think there's some subtlety in here. So there's no difference in the intention to treat, right? This is why I don't like data, right? Because then we start going into other parts of it and we start interpreting how we want. So again, I don't want to talk about Brian's data because he's here, but what I do think is he gets mad and it's not good. But what I think the subtlety here is methotrexate group 4% antibody rate at 1 year. The other group 20%. Okay, so maybe if you went past a year here, you would start to see the monotherapy group start to fall off. I think you would. Okay, trough levels, methotrexate group, much higher than the non-methotrexate group. And again, I would hazard a guess, if you kept following these patients out 2 years, 3 years, 4 years, this group would lose. So no difference in infectious complications, so that's good, we know it's safe. So de-escalation of combination therapy to me it's not about cost. Again, I've said my piece on patient practitioner preference. I don't really think that that's a good reason to quit. So what are we doing with combination therapy? So safety, there's no safety reason. I think we've shown that 1 year, and whether you want to continue on azathioprine or methotrexate, we don't know of any long-term, with the exception of the lymphoma and cancer risk of azathioprine. So we typically would say discontinue azathioprine at 2 years, but again, that's not a de-escalation because we will then add methotrexate to their regimen. I don't think there's a safety reason to discontinue methotrexate ever long-term, except for pregnancy. And again, I'm not saying this is safer, but you avoid disease-related toxicity, so I think it is safer in that sense. Efficacy, we know that the highest efficacy is combination. There's lower antibody rates and higher biologic concentration. So cost, no. Patient preference, no. Okay. So what are we doing in real life? To me, it's about the safety and efficacy, regardless of which regimen you choose. Efficacy, clearly, combination is the best. So if you're after safety, why are you using monotherapy with thiopurines? I don't quite get that. We know from the TREAT registry, which is people have mentioned today, right? Narcotics, steroids, those are the things that are really kind of dangerous or higher risk in our opinion. So if you look at infliximab, and this goes with all of the biologics, this is my main issue with dose interruption, de-escalation, whatever Dr. Abraham wants to call it, right? So this is from 2003, where these patients were episodically dosed with infliximab, 61% developed antibodies, okay? And this was before the era of widespread, you have to leave everyone on azathioprine or methotrexate, okay? And they basically were able to show if you have antibodies, right, so negative, low, medium, high, right, it's basically you're going to have less likelihood that you're going to respond to the infliximab. And this is probably translatable to adalimumab, to vedolizumab, to ustekinumab, sertolizumab, whatever you want. Antibodies, if they're persistent and especially if they're high, is bad. Well, why did these people get 60% antibodies? Because you episodically dose them. Okay, so beyond mesalamine, I think all regimens involve some immune suppression. Whoops. And the major risk is steroids and thiopurines, in my opinion, in terms of long-term risk, right? We don't think biologics lead to cancers, infections, you should immunize your patient. And it may actually be safer to use combo versus monotherapy with biologic. Clearly, the efficacy combination is the most effective therapy. So I've kind of morphed this into, this is how we should be treating people. And in the background, why would we de-escalate things? And if you agree with the above, if a patient fails mesalamine, you should initiate combo therapy, not monotherapy, unless there's a mitigating circumstance. If they achieve remission, consider if the thiopurine is necessary. That's the one thing I would agree with Dr. Abraham. We don't like thiopurines for long term because of the risk. And if you initiate thiopurine, consider changing it to methotrexate, because we don't know that there's a risk of cancer or lymphoma with methotrexate. And it's really, that's not really de-escalation, that's just switch. So to conclude, conclusions for the con argument. No evidence, no convincing evidence in my opinion to de-escalate mesalamine, methotrexate, biologic or combination therapy. I will concede that thiopurines, I think it makes sense to de-escalate that before 2 years. So we know de-escalation leads to flare, permanent loss of biologics, and maybe down in Texas they have more biologics than poor Seattle, but we only have a few, and we like to conserve things and not just burn through, you know, big gas-eating cars and things. So I'm just saying, we like to be a little more environmentally friendly and not just go biologic 1, 2, 3, well, let's see what else is coming. So again, a little gentler, kinder, gentler physician. And maybe Dr. Abraham likes to keep her surgeons busy, so she wants the complications from the natural history of disease. We tend, even though we work extraordinarily closely with our surgeons, as you heard Dr. Ramsey, he'd be thrilled if we didn't refer many patients. But you know, in Texas, go big, go home, so. So you should treat, despite my saying there's not a lot of data in my talk, you should treat according to the data, and not on the fear and the urban legend that she tried to generate. And one thing I would say about her, one of her main points was the story trial is, again, I like personal communication, so Brian personally communicated to me last night, oh, by the way, that 50% that was still doing well in the story trial, they're all flaring. They're all back on therapy. I think the other thing, she says, we can get 98% of people into remission. Just start them back on infliximab. But you have to leave them on azathioprine, right? These patients were left under immunomodulator. Well, I think we want to get rid of azathioprine, so why would we do that? Why not leave the biologic on? So I think that's the end. I hope you understand that I won. She's wrong. She's just a terrible, terrible person. Oh, wait, that I didn't say. Thank you.